Thank you for the opportunity to let me discuss the new leaflet technology on the horizon, especially with regards to transcatheter technology. These are my disclosures. I would like to take you back to the 10 commandments which were described by Dwight Harkane for an ideal valve substitute. It should not block blood flow, close promptly completely, it should be non-thrombogenic, resist infection, chemically inert, does not kill any cells, essentially easy and permanently implanted, allow healing to occur, pleasing to the patient, mainly no noise, and more importantly, last for lifetime. And needless to say that it doesn't exist because we have got essentially two substitutes which are mechanical and biological valves. And the trade-off on both sides is either thromboembolism and anticoagulation, which is needed with it, and structural heart failure with reintervention, which is needed with it. So we are still looking for the holy grail, so to speak, of an ideal substitute for valve replacement. The valve therapy has evolved because what it was in 1960s is not the same. So early experience of rheumatic heart disease with predominantly mechanical valve usage has slowly and surely gone to degenerative valve disease with more use of bioprosthetic valves. Similarly, patients tend to prefer tissue valves. We have seen life expectancy becoming longer. And all this has led to increased use and the need for a better bioprosthetic substitute. But any bioprosthetic valve substitute still fails, and age cutoff, which we use bioprosthetic valve, is still not clear, but is downtrending. When I started heart surgery training, it was 70 years, and now it is nearly 60 years. So again, we need better substitutes for this reason. Also, we need to have more durable substitutes, and hence this is a good balance to achieve with better understanding of what we have on the horizon. The advances could be technically divided into pericardial tissue, scaffold tissue, and polymer tissue. And let me address each of them separately. The pericardial tissue, there are three possible solutions. One is adapt tissue by Admidas, RESILIA by Edwards Life Sciences, and these two are already being used clinically. While slightly forgotten at present is porcine pericardium. As you know that the initial substitutes used in surgical and TAVR devices are essentially equine pericardium, bovine pericardium, and porcine pericardium. Adapt and Resilia are both modifications of pericardial tissue, which is bovine. However, we are yet to see any move from any manufacturer into more research in how to modify porcine pericardium as well. Let me start with ADAPT technology. This is essentially decellularized, cross-linked, and detoxified bovine pericardium. You can see the difference between glutaraldehyde and ADAPT-treated pericardium with no inflammatory infiltration seen. Collagen scaffolds remain intact, and at the same time, there's no DNA, so less calcium binding sites or zero calcium binding sites as claimed by the manufacturer. You can see that the DNA content of various substitutes which are currently used and CardioCell, which is essentially ADAPT technology, has zero, and this essentially transfers into a better pericardium. There is also a technique which is called samurai tissue technique, by which you can get as thin or even slices of pericardium, but more importantly, it maintains the mechanical properties and also allows 3D molding. 3D molding may become critical later for construct of bioprosthetic valves as there is more cooptation and more distribution of stress. This is just an example of how a single piece TAVR or a surgical valve can be built with single sheet pericardium, because you can see very nicely that this can be 3D molded, and this allows less stitches as well. INSPIRIS aortic valve now is one of the largest aortic valve prostheses implanted, and although we talk a lot about VFit technology, expansion and sizing, the critical part about this valve in my mind actually is the leaflet technology. As you know again that this is so to speak dry leaflet technology, but what it means is that it is not stored in a liquid which is glutaraldehyde. As you know, that glutathione fixation, as I mentioned before, leads to its own problems, and there are more calcium binding sites which are still available, which is eventually leads to degeneration. But I think with the RESILIA technology, what is claimed is again the glycerolization process leads to minimum exposure of these sites, and hence it has shown again a promise in sheep model where the calcium content of the similar tissue of perimount tissue, which is a gold standard, versus RESILIA tissue, actually RESILIA has shown much better performance, and hopefully this is transferred into clinical practice as well. What about scaffold? So one of the most promising technology in this field is ZERTIS restorative therapy technology, which is a bioabsorbable scaffold. The basic principle of any scaffold is to give a nice mechanical scaffold for its own tissue regeneration. Initial implants have been tried to my best understanding in pulmonic side. As you can see, some TAVR designs also have been implanted in animal. We will definitely await results of midterm and early of this particular scaffold in future. Finally, polymers. I think there's a lot of promise, and since I trained in heart surgery 23 years ago, I've been hearing about polymers, and not to my surprise that the first one was described in 1960s, which was a polyurethane tri-leaflet mitral valve, as rheumatic heart disease that time was predominant, followed by multiple silastic polymers and then PTFE polymers. The main challenge with all the polymers has been flexibility of the polymers when they're shaped in the tri-leaflet construct, degradation, which is mechanical degradation, and also degradation because of stress. Thrombosis, once the polymer degrades, it can actually lead to nidus for thrombosis as well as calcification. So a lot of new materials are emerging, such as biostable polyurethane called Bionet, Elaston, Pellethane, SIBS. And as you can see that the major challenge still remains is opening, closing at least more than billion times in a patient's life cycle. It is definitely going to expose the inner part, which is the frame of the polymer, and that itself can lead to thrombosis as well as tear and calcification. So I think we will still await results from early trials, which I understand has begun, and then see how it goes and whether it leads to not only increased durability but also elimination of anticoagulation. So what are the additional challenges in terms of TAVR design? Means most of these implants initially are carried out as surgical valves. Is what is the effect on polymer on crimping? What is the effect on coaptation if the valve's not deployed fully? What is the effect of additional balloon dilatation, especially with high balloon dilatation? So all this needs to be studied before it's really applied and becomes the mainstay in TAVR technology. So just to summarize, for near future, which I think at least 10 to 15 years, pericardium and modification holds the promise. And in distant future, I still think that polymer has many decades to go and to convince us that it's going to replace what is known as the pericardium or biological material. Thank you.